Thank you, Peter. Thank you, Maria, for the invitation. Ladies and gentlemen, I have a difficult task, and I hope I won't confuse you more than you might be already. It's a lot of disease we'll have to discuss, and not all those diseases are very common in cardiology discussions today. So my agenda is to review just briefly a few stroke facts, and then we'll go into the stroke, heart disease, and stroke. And I will divide it in congenital heart disease, which is a complex issue by itself, and heart disease with thromboembolic potential. And then I will spend a few slides on discussing intervention and stroke in cardiology. So this is a table showing the incidence of stroke these days, and you see there is a lot of variability in the incidence, and it is a disease which is highly age-dependent. So you have relatively little stroke in young patients, and you have a lot of strokes in geriatric or older patients, in men, and similar situation in females, although the overall incidence is lower. Now, just the diseases with thromboembolic potentials are widely spread across the spectrum of cardiovascular diseases. And this is a study which has been published 2014 in Stroke, showing that if you really study these patients and look after the causes of the stroke, about 20% of patients have macrovascular atherosclerosis as a likely cause of stroke, and there is a number of diseases listed here which may be potential causes of stroke. And there is another 20% of patients who have major cardiac disease, which appears to be likely cause of stroke. And obviously, you see listed here some of those. And you have a lot of patients where the stroke is not well defined, and apparently those patients is the atrial fibrillation a marker or cause, as Isabel said, a very important factor. Etiology is clear. We have ischemic strokes in majority of patients. About 4/5 of patients have ischemic stroke, hemorrhagic about 1/5 of the patients. Now, what is the definition of structural heart disease? It is any cardiac disease except a coronary disease. So all patients with valvular diseases or vascular heart diseases are patients with structural heart disease, per definition. Now, this is from a colleague of mine from her textbook on congenital heart disease. You have about 23 major causes of congenital heart disease, and you have far more individual variations. So each of these patients is an individual patient with a lot of specific abnormalities which define the cause, which define the disease in these patients. If you look at the incidence, the most common cause of congenital heart disease is obviously a ventricular septal defect. It's about 1/3 of patients, and the most frequent cause of right to left shunt heart disease is valvulotetralogy. And as I quoted here, it's the most common congenital heart defect in men altogether. So about 1% of live births have actually some kind of heart defect, which is surprising if you do not study this disease in particular. This slide shows important data that it's not only the small children or grown-up children, but you have a lot of patients with the improving care of congenital heart disease who reach even the adult age. And not surprisingly, you have even a significant number of patients who are older or even as we say, geriatric population now. So in the old days, it was the infants and children, and nowadays you have all the spectrum, all disease, all ages may have structural heart disease. Now the heart stroke risk in these patients are the common stroke risk factors, and as in other diseases. This is not anything specific. However, these patients have a lot of specific risk factors which are individual to those specific diseases. So you have a number of operations, you have type of defects, you have arrhythmias, you have foreign bodies implanted, so the endocarditis is much higher, you have polyglobulia, so the hypoxemia is a risk factor, and so forth. This pathophysiology is also a little bit different because these patients have a lot of shunts. It's not only DPFO as in healthy populations, but they have a lot of shunts across the pulmonary circulation. So the paradoxical embolism is relatively important in these patients, and there is a lot of embolic diseases going on. Now, this is just to show you the importance of the risk factors, atherosclerotic risk factors. There is actually only one hazard factor which is important in this study, and this is the diabetes mellitus. And if you look in this congenital heart disease population, you have all kinds of additional risk factors for stroke. Now this is data showing from Mandelakis study showing the incidence of stroke in population without, not necessarily healthy population, but population without congenital heart disease, so it's the general population. And you see obviously the increase with age is present. However, if you look at the patient with congenital heart disease, the stroke rises up very early on in the young age already, and continues to rise throughout the life of the patient. Now, how is it in adults? You have a rise in ischemic stroke with age in men and female, and the cumulative risk of stroke in patients with congenital heart disease, age 18 through 64, is in men about 7.7 or 8%, and in female about 6.9%. Now, how does it compare to general population? This data shows that in the younger patients, younger than 55 years old, the risk factor is 9 to 12 times bigger, and even in elder population, when obviously the risk of stroke is also increases is 2 to 4 times. Now, Dr. Marelli tried to have hierarchical qualification of stroke, and obviously Marelli 1 classification are very complex congenital heart disease patients with atrioventricular congenital defects. They are the patients with other complex transposition and so forth. Marelli 2 is the less complex disease. Marelli 3 is not specified and so forth. This Marelli 5 disease is probably the most complex. These patients do not have any specific classification. Now, if you look at the risk of these patients based on the Marelli classification, you see in this right lower corner the hazard risk ratio across the board is about 10.8, and the highest risk hazard ratio have the patient with Marelli 5, undefined congenital heart defects. Then Marelli 1 with the complex defined is about 12.2 and so forth. The lowest risk was assigned to a group Marelli 3 with the simple congenital heart defects. Now, if you look at the data based on specific defects, so for the whole group, the hazard risk was about 10.8%. And surprisingly enough, the highest hazard ratio was the coarctation of aorta. But in these patients, the risk is mainly for the hemorrhagic infarction. Now, this is a girl I am treating, also 6 years old, and you see she's born 2011, and she has a lot of, throughout her age, I don't want to go through all these, but she had a lot of surgeries, a lot of operation already. Some of these operations were even stopped because the thorax was so fibrotic that the surgeon couldn't do anything for her. So the risk of these patients is highly individual and I think difficult to categorize or classify for groups. Now we go to the patients with heart disease with thromboembolic potential, and again these patients are with valvular disease, primarily with cardiomyopathies and arrhythmogenic diseases. I certainly won't have time to go through all of these, but just to show you some of the data, this is the analysis of patients who present in cardiology clinic with different cardiac problems. And in these patients, there is just arrhythmia without structural heart disease. So if you wish, lung fibrillation, which probably doesn't exist, as Isabel said, about 20% of those patients had just isolated fibrillation, and about other 20% had isolated structural disease without fibrillation. And if you look here, the most frequent group was patient with atrial fibrillation and with structural heart disease, which is not surprising. And you have long list of different cardiac diseases which were associated with increased risk of stroke. This is just another presentation, and you see that in patients with atrial fibrillation, also the largest group had associated disease, even in patients who had hypertensive left hypertrophy. The largest group was associated with atrial fibrillation, and patients who had left ventricular dysfunction, the majority had also associated fibrillation. Now this is just the incidence. You might know this data. It shows that obviously the valvular heart disease increases with age. The most frequent is mitral regurgitation or insufficiency, shown in green here, and the right is the rising incidence of aortic stenosis as the second most frequent defect. Now these patients also have a lot of associated heart diseases. They are not just the valvular, but others as well. And you see the lifelong risk of these patients from diagnosis of valvular disease increases with the years from diagnosis, reaching 23% 7 years after diagnosis, which is very high. This is just a specific example showing the aortic stenosis. You see aging population and disease of the elderly. And in these patients who are not operated for aortic stenosis, the age is most important risk factors for stroke. The atrial fibrillation also as a marker or cause of stroke, very important, so the hazard risk is 2.7. And also, as not well-known fact, that the size of the atrium, left atrium, is also a critical risk factor. In patients who had surgery for aortic stenosis, the risk is also dependent highly on age, so elder patients have not surprisingly higher risk for stroke. And interestingly also, what we always for years discussed with the surgeons, the risk is if they operate and put a small valve into the situs, the risk of stroke is greater. Atrial fibrillation also not as important as the other ones, but still a factor. Now, I will go quickly through these. There are also the risk factors for a stroke, and this is studied by Dr. Otto, comparing patients with aortic sclerosis, not stenosis, and aortic stenosis. And you see, if you have no patients without aortic stenosis, the risk of stroke in this study was about 6.3%. Interestingly, just the sclerosis of stroke had increased the risk of stroke, and patients who had aortic stenosis obviously had the highest risk of stroke in presence of these multiple factors. This is just some data on mitral stenosis showing that atrial fibrillation is actually a marker of mitral stenosis, as it is well known in Europe. This disease is virtually eliminated because of the treatment of rheumatic heart disease, so we see very little patients with critical aortic stenosis. I'm speaking too long, says Peter, so I have to speed up. This is just showing that the atrial fibrillation is marker for stroke as well. I might skip these data showing the hypertrophic cardiomyopathy, also showing the individual risk factors this patient. This is maybe give me 2 more minutes, Peter. This is just a study showing risk of stroke in different procedures, and cardiac procedures are the leaders in risk of stroke, unfortunately, compared to any other medical procedures and even conservative treatment. And looking at the data, just cardiovascular interventions, you see the highest risk of stroke in this right corner, showing that the patients who have TAVI, who had left ventricular assist device, are the candidates for stroke. And this is just the data we published this year showing data on CAS, on carotid intervention, showing that stroke is even in different studies relatively important complication, and similar data on TAVI. And I would conclude, so congenital heart disease is a major lifelong independent stroke predictor of stroke. We have heart disease with thromboembolic potential is variable dependent stroke predictor, and fibrillation is important risk factor or marker. Stroke is relevant for cardiologists, and we should be able to treat or prevent the stroke. We will have Dr. Kovac who will speak tomorrow about prevention of stroke and intervention, and it's the next frontier in cardiology. Thank you very much, and thank you for your patience. Sorry for